Hi, everybody. Here is the GI lecture. So let's go ahead and get started. Okay, as you can see here is some basic anatomy of the GI system. You should be familiar with this. If not, this is a nice review. All right. Now, here's some overview. I think you'll notice the likeness of the picture I have here. I posed for it for hours. I like the ponytail touch myself, and I had bangs then, as you can see. Okay, I'm just teasing you guys. Anyway, um, the GI system begins with the mouth and ends at the anus. Not a shocker there. The system is divided into two components, the alimentary tract and accessory organs. All right, now the digestive begins in the mouth and continues in the stomach and small intestine. The large intestine is mainly responsible for reabsorption of fluids and electrolytes and eliminates the waste products. The accessory organs, as listed, are the teeth, tongue, salivary glands, liver, gallbladder, and pancreas. Okay, it's on your slide there. Normal functioning of the GI system is also dependent on actions of the nervous system and the endocrine system. All right, now here's some digestive enzymes that are at work in the GI system. Amylase is produced in the mouth. It helps break down large starch molecules into smaller sugar molecules. Pepsin, produced in the stomach, breaks down proteins and polypeptides. Trypsin breaks down protein in breaks down protein in the small intestine, then produced in the pancreas as trypsin. Let me spell that for you because I just butchered it. Trypsinogen. Now, pancreatic lipase, produced in the pancreas, enzyme that is a catalyst that breaks down fats and fatty acids and glycerols or other alcohols. Pancreatic lipase, produced in the pancreas as an enzyme that's a catalyst to break down fat to fatty acids and glycerol or other alcohols. Okay, so that's what's at work when you got your little margarita going on. All right, here's some GI conditions and emergencies. They're all listed there, okay? We are going to go over a few of those in detail, or most of them actually. Okay, gastric esophageal reflux disease, or GERD. You guys have probably heard of this, all right, because it's a chronic disorder that presents with a variety of clinical manifestations. Actual tissue damage may or may not occur as a result of the acid reflux from the stomach into the esophagus. Now, actual tissue damage. Remember, the acid you have in your stomach, it would burn you. If you guys vomited, right, and you've got the dry heaves and you get that burning sensation, that's the acid because you have nothing else left to bring up. Okay. Now, could it cause damage? Absolutely. It can cause breakdown in the esophagus. You can get an ulcer from it. It can affect people's breathing. My sister actually has GERD so bad, it comes up and tickles her bronchial in the lungs. So she's on an inhaler because of it. People like I have a persistent cough, and no, I don't have COVID. I've had a cough for a long time. They did a bunch of rule outs on my lungs, x-rays, making sure there's no tumors or cancers, and I don't have asthma and all that, but I still had this persistent cough that was really, really bad. I mean, it would make you jump. So they started me on an inhaler and Pepcid because I have something called silent GERD, as crazy as that sounds, and that causes the cough. So crazy. Okay, the reflux occurs when the lower esophagus sphincter, or the LES, you see it there, it's got an arrow pointing toward it. All right, the lower esophagus sphincter is weak or relaxing incorrectly, causing the pressure gradient between the LES and the stomach to be lost. Sorry, guys. Speaking of coughing, I coughed and needed a little water there. All right, GERD is a result of a temporary or sustained decrease in the LES competency. LES tone may also be affected by certain foods or substances. The lower esophagus sphincter, or LES, is a valve at the bottom of the esophagus that normally keeps acid from moving backward from the stomach. That's what it is. So some factors associated with decreased LES pressure could be a hiatal hernia, LES hypotension. What is LES hypotension? Basically, there's just not a lot of blood flow, substantial blood flow to the area. All of these you guys can read that can cause LES decreased pressure. I like this right slide here because, of course, obesity, that's a problem of everything. Tight belts or girdles. So there's another reason not to wear a girdle, you guys, right? In the presence of an NG tube. Now that, in other words, we're passing it through the nose down into the stomach. So we're going through the LES, the lower esophageal area there, okay, or sphincter. When we go through that, if an NG tube is in there for a long amount of time, it could actually decrease the pressure or the closing. Okay, hope that makes sense to you. All right. GERD results when there is a retrograde flow of GI contents into the esophagus. This will have the consequences of some level of inflammation. Reflux material in the esophagus normally returns to the stomach with the help of gravity or peristalsis, saliva. However, when the esophagus is inflamed or injured, the ability of the esophagus to clear reflux material becomes slower. So, in other words, you're eating, blah, 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 you're enjoying your chips and salsa. And normally, if something tries to come up, that sphincter will close. Okay? What this is saying, or what I just said about the esophagus being inflamed or injured, stops that from happening. So when you cough, you could cough something up, you could aspirate it. That's what I'm talking about. Okay, this results in an extended period of exposure of the esophagus to reflux material from the stomach. Each episode of acid reflux results in hyperemia, okay, which is increased blood flow, erosion, so you can have that ulcer I talked about, and possible minor bleeding to the esophagus. During reflux, other gastric substances such as pepsin and bile may be present, causing additional esophageal epithelial erosion. In other words, you could have an ulceration and it could bleed. Absolutely could bleed. Okay? Okay, so medical management. All right, so let's look at a variety of medical and surgical management options for GERD. 24-hour esophageal pH monitoring involves the placement of a catheter in the nose and terminating at the distal esophagus. The patient keeps a record of symptoms and activities throughout this process. All right, so they're getting an idea of what the patient's going through, okay? An EGD, that is an esophageal gastroduodenoscopy, you should say that 3 times fast, is utilized to evaluate esophagitis and monitor Barrett's esophagitis. Biopsy samples can be obtained and strictures could be dilated. These strictures occur as a result of fibrosis and scarring related to injury from consistent acid exposure. The esophageal manometer is the gold standard for assessment measuring LES pressure and peristalsis. Medications are used to inhibit an action, to increasing an action, or to protect. We will look at some of the examples of specific medication categories in just a little bit. Examples of endoscopy treatments are the Stretta procedure and the endoduodenal gastroamplification. Thank God I wrote it on there for you guys, because seriously, my speech anymore. The Stretta procedure involves the use of radiofrequency energy delivered with the use of a needle at the gastric esophageal junction, ESJ, to reduce pain by decreasing the vagus nerve activity. The EGP tightens the LES with sutures. Say that 3 times fast. This one right here. Okay. The complications listed here is Barrett's esophagus. In Barrett's esophagus, tissue in the esophagus is replaced by tissue similar to the intestinal lining. This condition is frequently related GERD and is thought to be a risk factor for esophageal endocarcinoma, cancer. The Nissen fundoplication may be carried out either as a laparoscopic procedure, which is the gold standard, or through an open laparotomy. Either way, the fundus of the stomach is wrapped around the distal esophagus and secured with sutures. Okay, so Barrett's esophagus. Okay, we're talking about medications. Oh, and I guess I should change the slide. Oop. Sorry about that. Let's go to previous. Let me go to previous. Not sure where the slide ended up. Sorry. Okay. That's one of the Nissen fundoplication that we talked about, the normal stomach and then after for the Barrett's esophagus. That's that photo there. Sorry, I got my slides a little bit mixed up. Okay. There's medication. Okay, a lot of medications, especially on our older population. Okay. Antacids increase the gastric pH. So Mylanta and Tums is an example. Okay. A histamine receptor antagonist decrease gastric acid production. It's short acting. So your Pepcids and Zantacs. Prokinetic medications increase gastric emptying. So Reglan. And protein pump inhibitors decrease gastric acid production, and it's longer acting. Right? And you'll also see in here I have anticholinergic and spasmodic. So you've all heard of Bentyl and scopolamine. It's transdermal, so it's a patch. So you may have heard of that when people might be going on a cruise or something to help with nausea. All right. About Reglan, the one thing about Reglan that I found interesting, usually Reglan is given at 5 p.m. and a Coumadin could be given at 4:30. And, normally we have time before and after medications are actually due to give them, right? You remember that from block 1. What's interesting is Reglan and Coumadin do not like each other very much. If you give them at the same time, Reglan actually decreases the effect of Coumadin. Okay, so just letting you know. I just think that's kind of an interesting tidbit. All right, so what do we need to do? Now, how are you going to plan for your patient's care with GERD? You're going to teach them to avoid types of foods that are strongly associated with decreasing the LES pressure, such as spicy and fatty foods, caffeine, chocolate, carbonated beverages. Oh my gosh, that's my entire diet. That is not going to be good for me. Hope that never happens. Also, some acidic foods, peppermint, and alcohol. Of course, right? Alcohol. Certain medications you want to avoid if possible, such as calcium channel blockers, anticholinergic medications, smooth muscle relaxers, which makes sense since the LES is a muscle. Of course, ideally, one should avoid smoking. It is important to eat meals at least 2 hours before lying down. You guys could probably think on that and go, yeah, because it gives the food some time to digest. So when you lie flat, it doesn't come back up. They need to wear non-restrictive clothing like that darn girdle. Don't be wearing that. And discuss activity levels and reinforce the benefit of maintaining an ideal weight. So they should get walking and not be obese, because obviously that was an issue as well. Patients need to consider methods to elevate the head of their bed at least 30 degrees. They could lie on the right side, which is a little bit better. Evaluating the head of the bed, you guys know, promotes peristalsis and uses gravity to return gastric reflux from the esophagus to the stomach. Obviously, if you're not going to lie flat, the chances of you having GERD is decreased the higher you sit. Now, 30 degrees is fine, which basically is 2 pillows, honestly. Maybe a little higher, maybe 3 pillows. Sleeping on the right side decreases reflux. Surgical patients will require that you focus your assessments to specific areas. If your patient has undergone a laparoscopic Nissen, which is the picture I showed you before, it is likely that he or she may actually be discharged on the same day. If they are discharged the same day, you'll provide instructional information related to a soft diet maintenance, medication administration, accuracy, activity levels, and infection prevention, which makes sense for basically anyone going home after surgery. Okay, so that's GERD. Nausea, vomiting. Goodness me. We all have it. Okay. Whoops. I'm getting ahead of myself again, you guys. Jeez. All right. Nausea and vomiting. Okay. Vomiting is a complex act that requires the coordinated activities of several structures, closures of the epiglottis, deep inspiration with contraction of the diaphragm. Okay? It involves the stomach, the lower esophagus, sphincter, and constriction of the abdominal muscles. And you've all felt that, right? I'm sure you have. Okay. So the etiology and the pathophysiology. The central nervous system, or CNS, disorders, for example, meningitis and tumor, okay, that can cause vomiting. Cardiovascular problems like an MI, heart failure. A metabolic disorder like diabetes or Addison's disease or renal failure can cause vomiting. Side effects of drugs, chemo, opioids, DIG, and some of the psychological factors like stress or fear. Okay, those are all real things, and we've probably all exhibited that. Some of you guys might have even exhibited it because we have a test coming up, right? Okay, so you can see what is involved in vomiting. The stimuli involved in the act of vomiting is a CTZ, or chemoreceptor trigger zone. Right here, I'm circling it. Okay, so that is what actually goes to our brain, and we say, oh, I'm going to be sick, right? That's what does it. All right, you guys probably know the clinical manifestations, but what I want to talk to you about is, as vomiting persists, severe electrolyte imbalances, loss of extracellular fluid volume, decreased plasma volume, and eventually circulatory failure could occur. So this can be pretty severe. Metabolic acidosis is less common than metabolic alkalosis. The threat of pulmonary aspiration is a concern because when you vomit, you can take a deep breath in, get your breath, but in the elderly or unconscious patient or patients with other conditions, they have a weakened gag reflex. So then you've got the stuff coming back down into the lung. To prevent aspirations, you want to put the patient who cannot adequately manage self-care in a semi-Fowler's or side-lying position. Okay, you always want to determine the underlying cause of vomiting. So what made them vomit? I mean, that's pretty much what you're asking. There was several years ago, I had horrible stomach flu. And being a nurse, of course, God forbid I get help, right? So I waited 2 or 3 days where actually on the third day, I couldn't urinate anymore. And I knew there was a problem then. Of course, I've been going to the freezer and trying to get an ice cube to stay hydrated. All right. It was kind of funny because I went into the ER where I worked, and I told the doc, I said, okay, I need normal saline. I need an antiemetic like Zofran. I had horrible stomach cramps too, and I said, I need Bentyl, which is an antispasmodic. I need Bentyl for my stomach. And he said, now hold on, hold on, hold on. I'm the doctor here. And then he turned to the nurse and ordered exactly what I said. And then he told me that he was going to get an abdominal x-ray and an abdominal CT scan. He said, and if that doesn't tell me what I want to know, I'm sure the autopsy will tell me everything. Of course, I busted out laughing, and I'm like, don't make me laugh, you know. I was so severely dehydrated. I started tenting. Before they gave me, and I'm not exaggerating, you guys, 5 liters of fluid before I even urinated. So, yeah, I was probably going into some kind of kidney failure as well. So this is not benign stuff by any means. Okay. All right, collaborative care. You can see here all the medications, but some of the common side effects to these meds could be a dry mouth, hypotension, sedative effects, rashes, and GI disturbances. I mean, they already have GI, but right, what's the normal GI protocol, right? I mean, what's the normal side effects? Nausea, vomiting, diarrhea, constipation. I mean, of most drugs, okay? All right, so we've got the IV fluids to replace. These would be isotonic solutions. I know we were talking about hypotonic versus isotonic for some issues. Hypotonic is normally used when it's a urinary issue. But for GI, it's normally normal saline unless they're electrolytes. They could be doing normal saline along with a half normal saline, depending on what their electrolyte looks like. If they're continually vomiting, they'll put an NG tube in to decompress the stomach. Clear liquids to start, very, very slow. Usually we'll even give them ice chips first to see how they tolerate that. Okay, so okay, we're going to talk about C. diff. As soon as I get it on the right, there we go. All right, here's what C. diff is. Most of you have probably had patients that have had C. diff. It is not uncommon by any realm. The treatment does include antibiotics. Even when treated with antibiotics, the infection may come back. In rare cases, fecal transplant or surgery may be needed. The thing about C. diff, if you're not aware of it, you know, there's poop smell, you guys. I mean, there is certain smell of stool. We all have it. Okay? What is different about this is this stuff will make your eyes water. I mean, it's just insane. Okay? It's frequent. It's usually thin. It's really gross. Okay? All right. The one thing too about pooping, isn't it weird about pooping, you guys? How, and I don't think this happens to the guys as much as the gals, but right, ladies, we go into the bathroom and we really have to go to the bathroom, really need to have that poop, and it's empty, so we can just let it rip. And then someone walks in the door and it's like we just stiffen our sphincter and go, whoop, gotta wait for water to run or someone to flush the toilet. Why is that? We're in a public restroom, for heaven's sake. But I think that's a chick thing. I'm not sure. And speaking of poop, have you ever, when you've gone to the bathroom, you've got those different kinds. You've got the splashback. You've got the one that's a holder on where you have to kind of wiggle in your seat to get it off. And then you've got the one that you poop, but then it's not in the toilet. Like, where did it go? Right? Those are very odd because you're never sure. Okay. That's nothing to do with C. diff, but just a little life lessons there. Okay, the medication, oral vancomycin and Difficid are now supported as the first-line options. Both are non-severe and both work on non-severe and severe initial episodes of this. So, sorry, I just, I got a little something in my throat. Okay, so it's oral vancomycin versus IV oral. All right, here's a picture of a patient going to do a fecal transplant that is stool in this saline bottle. And this is how it works. And that would not be a blender you're using for food, obviously. But this is how it works, okay? A fecal transplant has been shown to be effective in the therapy of reducing C. diff. A recent study has shown that this treatment delivery, either by a colonoscopy or an NG tube, appears to be equally effective. So yes, a patient can have an NG tube in and you're putting poop down the NG tube. But you know what? If you have C. diff, you really don't care how you're going to get rid of it, quite honestly. All right, hiatal hernia. The occurrence of hiatal hernias increases with age as supportive structures weaken over time. Around 60% of those affected are 50 years old or older, and most are asymptomatic. It's interesting to note that the prevalence is significantly greater in Western countries than in African countries. The significant difference is known to be a result of the lack of dietary fiber and the unnatural position of defecation. There are two types of hiatal hernias, a sliding and a rolling, or a paraesophageal hernia. This is a consolidated or an overview of the pathophysiology of a hiatal hernia development. As the ability of the JEJ becomes impaired, the reflux takes place, and the ability of the esophagus to remove the acid becomes compromised. Okay, so the GEJ is also known as the gastroesophageal junction. Gastroesophageal junction. I don't think I mentioned that before. All right, some clinical manifestations. You can read most of them. Listed on the slide there are the common symptoms that patients describe. More commonly, you will note symptoms such as those mentioned under type 1 hernia. Type 1 hernia is considered to be an acquired condition caused by trauma, hereditary weakness, or congenital large hiatus. The type 2, or paraesophageal hernia, occurs due to an anatomical defect that causes the improper anchoring of the stomach below the diaphragm. This type of hernia presents with different symptomologies. Reflux is not usually present because the LES remains secure below the diaphragm. All right, so how do we take care of these guys? Management of the hiatal hernia is listed under medical and surgical options. Medical management commonly utilizes X-ray, a barium swallow, and an EGD. Antacids and proton pump inhibitors are used for symptomology if present. Complementary medicine does not have evidence or clinical trials to support its use, but that doesn't necessarily reduce its efficacy. So you see there, I've got complementary medicine and massage. I say if it works, go for it. Okay, this is a treatment that utilizes massage therapy to purportedly push the stomach back into its normal position below the diaphragm. Surgical management is carried out typically by performing an LNF, a laparoscopic Nissen fundoplication, and I showed you that picture. A herniorrhaphy repairs the hiatal defect, and herniotomy surgically removes the herniated sac. All right. Herniorrhaphy, sorry, that first word there, you can see that spelling. And I didn't butcher that one as much as you think I might have, promise. Okay, remember that your patient with a hiatal hernia may be asymptomatic, making this diagnosis likely an unintended find. Typically, the clinical manifestations are worse after meals due to the displacement of the stomach contents into the thoracic cavity. Your cardiovascular assessment, you want to evaluate for chest pain, and you always rule out the cardiac cause first. Palpitations may develop secondary to irritation of the vagal nerve. Respiratory assessment. Respiratory and asthma-like manifestations are a result of aspirating stomach contents. This occurs mostly while sleeping. After eating a large meal, patients may experience a feel of breathlessness or chest pain if the herniation interferes with lung expansion. It is critical that you assess oxygenation and lung sounds. You're looking for patient color, respiratory effort, O2 sats, right? All that jazz. Okay, GI assessment. You should include frequency and amount of nausea and subsequent vomiting episodes, particularly in those patients that are unresponsive to any antiemetic meds. So you're giving them like a Zofran and it still doesn't help. If nausea and vomiting is a consistent issue, consider the possibility of a gastric volvus. This volvus or strangulation can lead to GI tract or esophageal obstruction. Assess your patient for dysphagia, commonly the result of strictures and lower esophageal mucosa rings. Okay, so that happens when you have esophageal or mucosal damage. So nutritionally, the potential for a decrease in adequate intake as a result of nausea, vomiting, dysphagia, and hiatal symptomology is pretty common. The rationale for taking a look at the hematological status is that these herniated gastric pouches are likely to have erosions and ulcerations causing a state of chronic blood loss that may lead to anemia. Teaching your patients about the importance of positioning is an important consideration to support emptying and increasing peristalsis. Medication management. In a timely fashion when necessary, always follow administration with assessment related to efficacy. In other words, only give them meds that are going to help them make it work. Okay. Any education that you give them, you need to work with your patient in assessing the willingness to make certain lifestyle changes, weight reduction, tobacco and alcohol avoidance, stress control, sleeping position changes, as much as what we just addressed in GERD, position, meal timing, and food choices. The same things apply for hiatal hernias. Ulcer disease. For a definition of terms, I want you to consider that an ulcer has considerable depth, whereas the term erosions break the surface but do not have measurable depth. So, for example, you break your skin, whatever. Someone cuts you, you fall, whatever. Okay, that's just broken skin. Depth is measured if that break turns into a wound. And you guys have seen wounds on patients that can tunnel. That's what that means. Peptic ulcer disease includes both ulcerations and erosions of the stomach and duodenum. Duodenal ulcers make up about 80% of peptic ulcers. These ulcers affect the proximal small intestines and are characterized by a period of remission and exacerbations. Chronic gastric ulcers are likely to occur in the lesser curvature of the stomach near the pylorus. Okay, so here's the duodenum, ulcer, okay? Okay, so this is a disease that is extremely common in the US. Most individuals affected are between the ages of 25 and 64, so there's quite a span. Historically, it was believed that stress and anxiety were the caustic factors in acquiring the disease. But now research has shown that the infection with gram-negative organisms, H. pylori, and chronic use of NSAIDs are likely responsible for the development of ulcerations. Helicobacter pylori, or H. pylori, releases a toxin that promotes mucosal inflammation and ulcerations. Now, everybody has H. pylori in their body. H. pylori is specifically the reason why most of the patients in the hospital are on some kind of protein pump inhibitor or something like that. Okay. There's also a connection between peptic ulcers and certain medical conditions like COPD, in chronic renal failure. Other causes to be considered are irritants, alcohol, smoking, trauma, psychogenic factors, and aging. Many patients have few or no symptoms. If symptomatic, patients' chief complaint is pain, often of a burning sensation that is more intense when not eating and improves with intake of food or antacids. That kind of makes sense because you've got the acid working overtime there. So when you have food, it neutralizes the acid. The acid has something to do. Gastric ulcer pain is triggered by eating occurring shortly after meals, and the individual does not get relief from antacids. So that's where you're like, that is a gastric ulcer. In this case, the increased acid content of the stomach and duodenum erodes the lesion and stimulates the exposed nerve endings. It's like pouring salt into a wound. Okay. Okay, medical management of peptide ulcer disease. All right. And we're going to look at more medications and surgical goals as we move into GI. But here listed are just some of the things. Okay, appendicitis. Here's some of the symptoms. Murphy's triad. Okay, so let me tell you guys something about appendicitis. There's all these rumors. If you hop on one leg and you don't have pain, or you do have pain, you have an appendicitis. Rebound tenderness, where if you were to push down on the stomach and lift up, and they have pain, not when you push down, but when you lift up, then it is an appendicitis. That is false. It can happen on some people, but mostly when people come with appendicitis, it will be seen on a CT scan. They will have pain, fever, and vomiting. So that's Murphy's triad: pain, fever, and vomiting. They'll have increased white blood cell counts because there's an infection. Okay. And on the CT scan, they'll see a calcification possibly, or they'll see it burst. They'll see it inflamed. Okay. So I do want to tell you guys, a friend of mine's husband had just this pain that would not go away. And they thought, and she's a nurse, and they thought for sure it was appendicitis. Well, over a few months, they're like, we don't see anything. We don't see this. We don't see that. Now, mind you, no one likes to do what we call an exploratory lap, or basically you open up the belly and you do surgery. No one likes to do that without really knowing what's in there. That's why it's called an exploratory. But with that said, so over several months, and I'm thinking 3 or 4 months here, he kept having this pain. It got worse and worse and worse. They weren't showing anything in CT, all that. Finally, my friend says, you just need to open him up. And the husband was like, yeah, I don't care what it is. You need to open it up. So they opened his tummy, and they saw that the appendix had burst some time ago, and it wrapped around the bowel. So that's where his pain was coming from now. So when he first came in with pain, he probably had a ruptured appendix, and for whatever reason, they didn't see it. CT scans are not 100%. I mean, the patient is still having symptoms. You need to figure out the problem. So anyway, fortunately, they were able to clean him out. He never ended up with a colonoscopy. A colonoscopy, seriously. He never had to have a bag, anything like that. So they managed to close him up. But that was all by an exploratory lab. Okay, GI bleeding. The bleeding can occur at any point along the alimentary tract. However, an upper GI bleed is 5 times more common than a lower GI bleed. Together, they account for a significant morbidity with a mortality rate of anywhere from 7 to 10%. For an upper GI bleed, mortality can be greater than 40% in patients with liver disease or other serious illnesses. Duodenal and gastric ulcers account for half of massive upper GI bleeding disorders. Stress ulcerations are known as erosive gastritis and tend to be multiple shallow lesions located in the proximal stomach. Gastritis is another common cause of GI bleeding. This type of bleeding usually occurs as slow, diffuse oozing that is difficult to control. Okay, the small intestines account for only a small portion of all GI bleeding. Diverticular disease, or diverticular disease, sorry about that, I swore a little bit, arterial venous malformation, indisposition of the small bowel, acute superior mesenteric artery occlusion, Crohn's disease are just some of the possible reasons why you're bleeding in the small bowel. Okay, arterial venous malformations of the ascending colon and the cecum is the usual cause of massive colonic bleeding. Inflammatory bowel diseases result in friable intestinal mucosa, which can lead to massive hemorrhage, bowel obstruction, and perforation. Diverticular disease, more common in the large bowel, can cause serious intermittent bleeding episodes. With respect to the neighboring organ causes for GI bleeding, acute pancreatitis and pancreatic pseudocysts are disorders associated with hemorrhage. A pancreatic pseudocyst is a collection of fluid around the pancreas. The fluid in the cyst is usually pancreatic juice that is leaked out of the damaged pancreatic duct. Hypoperfusion associated with decreased cardiac output or volume depletion can lead to GI ischemia, resulting in the necrosis and hemorrhage. A high incidence of GI bleeding is associated with uremia because of platelet dysfunction. Collagen diseases can result in thrombosis of small vessels in the small intestine, eventually leading to ulceration. And blood dyscrasias like DIC or thrombocytopenia are associated with hematemesis and melena causing by decreased clotting. Medications and trauma are also definite causes of GI bleeding disorders. All right, so how are you going to assess the GI bleed? Well, many times they just come to you and they're bleeding profusely from the mouth and or the rectum. I have to tell you guys, when I was working in ICU, I worked with this gal Maureen, or Mo. She's the kind of nurse that you could have her hair set on fire and she'd stay calm and go, could someone just put that out for me? I mean, she was always so calm about everything. And one day she got this patient in. She shut the door, closed the curtain. Now they're glass doors, but closed the curtain. And I hear her say, hey, Kathy, can you help me out in here? And I'm like, yeah, sure. I get up and I see the stool that's coming across the room to the door. And of course, it's one of those things you're worried, like if you're going to open the door, the whole flood will come out. And of course, that didn't happen. So I put little booties on my sneakers and I lay down towels as I'm entering. And this guy, there's nothing like smelling stool and blood at the same time, not to mention alcohol. So it stunk. So we're helping this guy. The funny thing is, the GI doc comes in, walks in. It's like he doesn't even realize the guy is profusely having a lot of stool. It's incredible. And the doctor says, oh, did you guys get carpeting in here? Because he was stepping on the towels. And we're just looking at him, and we are head to toe covered with protective gear, so we wouldn't get the stuff on us. And he goes, oh man, these are new shoes too. I mean, hello, know your surroundings, people. But yeah, GI bleeds can be super messy. So how do you assess them? The assessment of the individual with a GI bleed, again, includes obtaining the accurate history, noting what the patient looks like, and how she's presenting or he's presenting clinically. So vital signs, that kind of stuff. What are you learning from your physical assessment, and what data are you able to obtain? What might identify your patient for increased risk for GI bleeding? For example, medications, any critical illnesses, alcohol. Okay, So critical illnesses, especially a major injury, surgery, a CNS disorder, burns, organ failure, all of those are major. Is there a history of inflammatory bowel disease, hepatic, pancreatic, biliary tract disease, or ulcer disease? Has your patient or family documented history of excess alcohol use, NSAIDs, or steroid ingestions? When assessing for clinical presentation of hypovolemia, remember that adults can lose up to 500 milliliters of blood in 15 minutes and remain asymptomatic. So those big liter bags, a patient can lose half of that and still not have any symptoms yet. So if that's occurring, you need to think, if this keeps going, all of a sudden the patient's going to be asymptomatic or crash, as we say. They're going to get tachycardic, get hypotensive. So we want to stay ahead of it. Okay? If there is a liter loss in 15 minutes, you will see tachycardia, hypotension, nausea, weakness, diaphoresis. Massive hemorrhage is generally defined as a loss of above 30% of total blood volume or bleeding episode that requires transfusion of 6 units in 24 hours. The most blood I've ever given anybody is 15 units. There's people that have given a lot more. Upper GI bleeding commonly presents with emesis, bloody emesis, which is bright red, indicating fresh blood. Upper GI bleed. Coffee ground, which is older blood that has been in the stomach long enough for gastric juices to act on it. So you could see that. Blood may also be passed via the colon. Melinea is shiny, black, foul-smelling stool. It results from the degradation of blood by stomach acids and intestinal bacteria. Bright red or maroon blood can also be passed from the rectum. Usually, maroon blood is a sign of lower GI source of bleed, but can be seen in upper bleeding is massive. Occult blood is determined by testing the stool with a chemical reagent called a guaiac. Now, we used to be able to do that at the bedside, you guys. Even though the guy might be spitting up red blood, you still have to get the little card out, and it shows you on the card, pardon me, where you put the stool, and then you have to send it to lab, and they have to do the guaiac now. I think it's an insurance thing, because someone wasn't making enough money, I guess. The physical assessment may determine the presence of tachycardia, hypotension, cool and diaphoretic extremities, decreased peripheral pulses. They could have delayed cap recell, pallor, they're restless, confused, decreased urine output, and bleeding. Now, none of that sounds crazy to you because that's someone who's dehydrated. Auscultation of the abdomen may reveal hyperactive bowel sounds as a result of the mucosal irritation from blood, or it may be silent. Palpitation may disclose tenderness or a mass. The patient may appear diaphoretic, pale, jaundice, or cyanotic. Again, vital signs are a quick indicator of the hypovolemic state. Hemodynamic indicators usually show a decreased cardiac output. All right. So there's just some things that can happen. So it's definitely not benign by any means. Okay. All right. Risk factors that you might want to consider on your assessment of patients. Those who demonstrate a large volume blood loss and have not been transfused with above 6 units of blood prior. Indicators of shock. Are they tachycardic, hypotensive, increased respiratory rate? Is their color pale? Is their temp increased? Any changing LOC? Adults over 60 increases your risk factor. Those presenting with any initial sign of hemorrhage or bloody emesis. Endoscopy findings indicating recent bleeding. Bleeding that is not related to the primary diagnosis. All right, some diagnostic tests. Hemoglobin and hematocrit values will reflect the amount of blood lost. Because of the ration of blood cells to plasma remains unchanged initially, the first hematocrit value may be near normal, but will fall dramatically as volume is restored and estriol value of fluid mobilizes into the vascular space. That's hemodilution. Platelet count will rise within 1 hour of hemorrhage, and leukocytes increase. If the patient was to be vomiting excessively, they could be hypochloremic and hypokalemic. Numbers will appear along with the increase in bicarb. BUN will rise, but creatinine will not, due to an increase of intestinal protein from the digestion of the RBCs. Elevated BUN is seen with upper GI bleeds as protein digestion occurs higher in the GI tract. Hyperglycemia is a result of the body's response to stress, and hyperbilirubinemia is from the breakdown of the reabsorbed blood. ABG may return with severe lactic acidosis as a result of severe shock. Lactic acidosis, if they're above 2, you're concerned. Severe is 4. Depending on the pre-existing disease, hypocoagulability may be present. ECGs may reflect severe cardiac ischemia as a result of hypoperfusion. An EGD is the most common accurate means of determining the source of upper bleeding. Okay. Descending colon bleeds are visualized during the proctosigmoidoscopy. Flat plates of the abdomen will show if free air is present, suggesting a perforation, and you may see chest fills to determine baseline pulmonary status. If the bleeding is suspected to be an arterial in origin, angiography is utilized to locate and identify and provide a pathway for therapeutic immobilization. So, what did I just say? The EGD is the best way. If you're in an ICU, they will come to the bedside. They will put a tube down their throat or up the buttocks, and they will find where the bleed is and cauterize it. They might have several bleeds, but that's the whole point, is to try to get this taken care of, because they'll just keep bleeding. All right. So some of the endoscopy modalities include laser, heater probe, injection therapy are generally effective at stopping the bleeding. Early endoscopy increases diagnostic accuracy, reduces the risk of rebleeding, and decreases the length of hospitalization. Okay, so we're going to look at pharmacology in just a minute. Okay. I'm sorry, I thought I was going to say something else. I lost my place. Okay. Sigmoidoscopy, colonoscopy may be useful for lower GI bleed. Gastric pH monitoring is performed to assess the pH of gastric contents or of gastromucosal tissue. The goal of the therapy is to maintain gastric pH within a given range, usually 4 to 5. Because the gut is especially vulnerable to ischemia associated with hypoperfusion and septic shock states, pH monitoring is a predictor of intestinal ischemia, sepsis, and multisystem organ dysfunction. Surgical intervention is dependent upon the location and severity of the bleed. If ulceration diseases continue to bleed in spite of aggressive medical therapy or complications such as perforation or obstructive development, surgery may be indicated. All right, volume replacement in acute GI bleeding must be performed as quickly as possible. 2 large bore IV lines are inserted and rapid fluid resuscitation is initiated. What that means is a normal IV a bore might be 20 gauge. We're talking 18, 16, 14, which can water your lawn pretty effectively, actually. And rapid infusion means you open it right up. And like we talked about in the IV lecture, they can put it in something that compresses it, so it can go in really quickly. So you're going to use normal saline or LR. Patients with unstable vital signs and poor tissue oxygenation should be transfused. Packed red blood cells and fresh frozen plasma should be balanced to provide replacement of cells and clotting components. Hemodynamic monitoring is essential for continuous evaluation of the patient's volume status. Remember, the overaggressive resuscitation results in fluid volume excess with complications of cardiac failure and pulmonary edema. So in other words, when you're giving them lots of fluid, you need to assess them. Making sure the fluid is going where it needs, not in the lungs, the edema isn't occurring, okay, that kind of stuff. Because of a decrease in oxygen carrying capacity of the red blood cells and massive blood loss, oxygen therapy by cannula or mask is initiated. Sometimes they lose so much they end up on a vent. Okay, continuous oximetry monitoring is required to make sure that we're getting what we need. But you guys, even when they're on a pulse ox, do not forget to assess the patient. Pulse ox is a great thing, but it's just a machine. Ventilator support may be required, as I just said. Following hemodynamic stabilization, nutritional support must be considered. Usually in this case, it's in the form of TPN. TPN. We usually don't feed the gut because it's a GI bleed, so it's TPN. Once the GI bleed has subsided, then we could feed the gut. Via tube in the nose or something like that. Gastric lavages are often necessary for upward GI bleeds. This is performed using room temperature saline to clear blood clots from the stomach and allow for an estimation of ongoing blood loss. It is avoided if esophageal varices is suspected, because that means we have to put down an NG tube. And if they have an esophageal varice, which is in the esophagus, in the throat, then we could actually irritate it more. Okay. Of the pharmacological agents used to treat active ulcer bleeding and to prevent rebleed, including H2 receptor antagonists, proton pump prostaglandins, vasopressin, only proton pump inhibitors show sufficient evidence of efficacy. Okay. Gastric alkalization with antacids, histamine, H2 receptors, and other agents is marginally effective in preventing and controlling ulcerations. These medications may actually contribute to nosocomial pneumonia as a result of increased gastric bacterial counts and the possibility of aspiration. So antacid, histamine, H2 blockers, they can actually hurt the patient more. Antacids are specifically utilized to raise the gastric pH and decrease corrosiveness of gastric acid. They may have an effect on pain levels. The H2 receptor antagonists block gastric acids and pepsin secretion. Sucralfate is often prescribed for patients with gastric erosions. This medicine combines with gastric acid and forms an adhesive protective coating over damaged mucosa. So it's like a little blankie. This often results in constipation, though. You know, there's always a trade-off, guys. Okay, so Cytotec is a synthetic prostaglandin that enhances the body's normal mucosal protective mechanisms and decreases acid secretion. Prilosec is a proton pump inhibitor. It deactivates the enzyme system that pumps hydrogen ions from the parietal cells, thus inhibiting gastric acid secretion. And vasopressin, an octreotide, decreases visceral blood flow via vasoconstriction. All right. Sandostatin is commonly ordered to slow or stop bleeding by decreasing the splanchnic blood flow and reducing portal pressure. Vasopressin is secondary medication in the treatment of esophageal variceal bleeding. It lowers portal pressure by vasoconstriction of the splanchnic, or also called visceral arterial bed. Ultimately, it decreases pressure and flow in the liver collateral circulation channels to decrease bleeding. Vasopressin has significant GI, nausea, vomiting, diarrhea, cardiovascular dysrhythmias, decreased LOC, side effects. Therefore, it is the second choice. So that's kind of GI bleed down and dirty. Okay, irritable bowel syndrome and inflammatory bowel disease. These two images will give you a visual description of the differences between irritable bowel syndrome and inflammatory bowel disease. In the patient with irritable bowel disease, or IBS, the layers of muscles that line the intestinal walls contract and relax. This is the process that permits the movement of food through the digestive system. In IBS, these muscles function abnormally, producing painful muscle spasms. Inflammatory bowel disease is an umbrella term for two very similar chronic diseases of the GI tract: Crohn's disease and ulcerative colitis. All right, irritable bowel syndrome. Unfortunately, the causative factor or factors for the development of IBS have not yet been identified, and research have found no cure. Women are twice as likely to suffer from IBS than men are. Congratulations, ladies. It is classified as being constipation dominant, diarrhea dominant, or a mixture of both. So one time you could have diarrhea, the other constipation. An example of clinical indicators for IBS include symptoms that improve with defecation, stool frequencies, or appearance changes, pain relief after bowel movements, and abdominal distension. A wide variety of medication therapies exist and are focused on symptom relief only. Complementary therapies include techniques of relaxation, acupuncture, probiotics, regular exercise, massage, and meditation. Complications are related to psychosocial concerns. Patients often become isolated as a result of their symptoms. Nursing management includes assessment of vital signs. You are measuring physiological function related to other causes of the symptoms. So, for example, if you were suspecting someone was getting dehydrated because of diarrhea, okay, you're looking for hypotensive issues, tachycardic issues. You're also assessing a pain. What makes it better? Defecation? What makes it worse? Certain foods. Assessment of bowel patterns. Are they constipated? Do they have diarrhea? Do they have both? Conducting a psychosocial assessment. It could be revealing particular stressful events that may cause symptoms. Okay? Crohn's disease. It can affect any portion of the GI tract from the mouth to the anus, more common in terminal ileum and colon. It affects all layers of the bowel and is not uniform in its appearance. The lesions cause deep ulcerations between layers of edematous tissue. With each exacerbation, the intestines become more scarred, leading to a decrease in the ability to absorb nutrients. Because this disease is transmural, it may actually penetrate the bowel wall, leading to fistulas, abscesses, and peritonitis. While you might have people have Crohn's, this stuff's not benign at all. It can cause the whole GI tract to become infected. Okay? Now, ulcerative colitis. Ulcerative colitis involves the mucosa and submucosa of the large intestine. This disease spreads evenly, beginning at the rectum and spreading upward toward the cecum. Diarrhea is a very common manifestation. This can be a significant problem as patients may have greater than 20 stools a day. Yes, I said 20. Losing several liters of fluid in the process. When you assess the stool of a patient with ulcerative colitis, you are likely to note blood, mucus, or pus. Remember what we don't chart, people. Okay, so purulent. Okay, so patients may manifest something called tenesmus. This is a spasm of the anal sphincter along with a constant desire to empty the bowel. Could you even imagine that? That would be horrible. Ulcerative colitis also produces scar tissue and again interferes with absorption of nutrients. The primary goal of medical management is to rest the bowel and control the inflammation. Additional medications are utilized to decrease inflammation and suppress immune responses. Patients with ulcerative colitis who have failed medical management may undergo a colectomy. A proctocolectomy involves a removal of the colon and rectum and permanent closure of the anus. So obviously they would need an ileostomy is in place there. It's also called K-O-C-K pouch. It's pronounced cock pouch, but I wanted to spell it because you're crazy kids in there. Okay. All right. All right, so what are some of the managements and nursing interventions we can do? Vital signs are often within normal limits, unless, of course, there's a major fluid loss. The patient may develop signs of dehydration. Remember that the recurrent diarrhea results in malabsorption of nutrients, so you may want to help your patient maintain an intake diary. It's really important. What are they eating? Excessive diarrhea also is cause for concern, so you need to monitor your fluid and electrolyte balance. Also know that blood is common with ulcerative colitis, but rare in Crohn's disease. Patients often do not eat or drink for fear their symptoms may reoccur. So I's and O's are critical to monitor. Daily weights are necessary to monitor nutritional status. Normally, you might consider albumin levels, but factors such as inflammation and infection can alter albumin levels. Fluid and electrolyte losses occur through diarrhea. These patients are often victims of symptom-related social isolation. Because if you always feel you have to go, nobody ever wants to go out then. That's no fun. Okay, so we're moving on to bowel obstruction. I've got them numbered, what they look like. An intestinal obstruction occurs when blockage prevents the normal flow of intestinal contents through the intestinal tract. That's an obstruction. Mechanical obstructions most commonly affect the small bowel, with most common type being adhesive. Non-mechanical or functional obstructions are often a result of a paralytic ileus occurring as a result of malmanipulation in surgery. So you guys are looking at this, and I know the first thing that comes to mind is, oh my gosh, are we going to have to memorize this? No, there's not going to be a picture, and you pick up the bowel obstruction. What is really important is how do you recognize bowel obstructions, and that it is an emergency. It is an emergency to take care of this. Initial symptomology will likely include your patient's cramping pain that is wave-like due to persistent peristalsis, both above and below the blockage. The patient may pass blood and mucus, but no fecal matter and no flatus. Now, or flatus, or farts, or toots, or whatever you want to call it. Professionally, we call it flatus. So, why is that? Because you have a blockage. That is why nowadays, when I was first a nurse, everybody had to stool before they left the hospital. Now they just have to pass gas. Okay, because passing gas, air always gets through. Air always gets through, so we know that's not completely blocked. But in this case, they don't. Vomiting may occur. If the obstruction is complete, the peristaltic waves initially become extremely vigorous and eventually assume a reverse direction, with the intestinal contents propelled toward the mouth instead of toward the rectum. Okay, if the obstruction is in the ileum, fecal vomiting will occur, so they will throw up their stool. Signs of dehydration are likely to become evident: intense thirst, drowsiness, general malaise. They're achy, they have dry mucous membranes. As you guys know, vomiting results in the loss of hydrogen ions and potassium from the stomach, leading to reduction of chlorides and potassium in the blood and to metabolic alkalosis. With the acute fluid losses, hypovolemic shock may occur and possibly septic shock. Large bowel obstruction differs clinically from small bowel obstructions in that the symptoms develop and progress relatively slowly. All right. Radiology studies will show abnormal quantities of gas, fluid, or both in the intestines. Elevations in white blood cell counts may point toward a strangulation or perforation of the bowel, perforation a hole. Hemoconcentration is reflected by an raised hematocrit. If your patient is bleeding, hematocrit and hemoglobin are likely to decline. Electrolytes are useful in monitoring the level of dehydration. The NG tube is critical for decompression of the stomach and bowel proximal to the obstruction. As a result of the dehydration and electrolyte depletion, IV fluids and replacements are necessary. Timely and ongoing administrations of prescribed analgesics is required. If the bowel obstruction is a result of inflammatory or infectious causes, antibiotics are likely to be ordered. Conservation treatment is preferred. Conservation, like I'm saving a tree. Conservative treatment is preferred and is likely to resolve many obstructions. If this path is not effective, emergency surgeries will occur. If the obstruction is located in the small bowel and is the result of previous surgeries, conservative treatment has a high rate of success. So we just don't want to run everybody to surgery. But, we've got to make the bowel work, so we do the best we can. Okay, so we have a number of roles, guys, and we mentioned the NG tube. You have a number of roles on a bowel obstruction. The NG tube assessment and function is critical. The placement and quality of volume of output, your I's and O's. With relation to fluid and electrolyte balance, frequent assessment of hydration status is necessary. So think about how you would do that. Lab value review and assessment from symptoms of abnormal values. You will monitor and assess nutritional status, your general ongoing assessment, return of normal bowel sounds, changes in abdominal distension, subjective changes in abdominal pain and tenderness. Is your patient now passing flatus or stool? You must immediately report changes in I's and O's, increasing pain or distension, and increased NG output. Okay, that means it could be gearing up for something bad. Okay. Okay. All right, we're going to talk about diverticulitis. When a patient has diverticuli, the colon wall thickens and becomes rigid. Without adequate fiber intake, more water is absorbed from the stool. This slows movement and creates a more difficult passage of stool through the colon, which you probably learned in Block 1. It is believed that this process increases the pressure within the lumen from the constant straining and constipation, which leads to the formation of a diverticula. Inflammation happens commonly as food becomes trapped in these pouches or the diverticulum. This can be acute or chronic. Medical treatment for uncomplicated diverticulitis is treated on an outpatient basis with broad-spectrum antibiotics. Usually the patient will be NPO with slow advancement of symptoms as the symptoms subside. Complications of diverticulitis include perforation, abscess, fistula formation, bowel obstruction, and bleeding. Nursing assessment requires monitoring of vital signs. So you have elevated temps occur as a result of inflammation. Potassium levels, if the patient has an NG tube placed, potassium increases. Pain, looking for signs of ruptured diverticulum and subsequent peritonitis, and their mental status. In older adults, it may show signs of mental status change that are the first indicator of an infection. Not fun, this stuff. A GI perforation. Okay, it's a hole that occurs in the stomach and the duodenum in the intestinal tract. When this occurs, there is a release of gastric or intestinal contents into the peritoneal space. Causes vary. Symptoms develop suddenly with severe pain, followed shortly by signs of shock. Esophageal, gastric, and duodenal perforations will manifest unexpectedly with abrupt onset of an acute abdomen. Severe generalized abdominal pain, tenderness, and peritoneal signs. Pain may radiate to the shoulder, just where the nerves are. Perforation at other GI sites often occurs along with other painful inflammatory conditions. Because such perforations are often small initially and frequently walled off by the omentum, pain often develops gradually and may be localized. In all types of perforation, nausea, vomiting, and anorexia are common. Bowel sounds are quiet to absent. Assessment includes your blood pressure, pulse, respiratory rate and temperature, respiratory status, circulation status, and abdominal assessment. That is what it includes, okay? Etiologies of the perforation. These are where it can happen. Trauma, surgery, esophagus, forceful vomiting. You guys can read this. But these are the areas that a perf can occur based on the causes to the right. Peritonitis. Primarily, peritonitis is a bacterial infection that occurs spontaneously without any apparent source of contamination. It occurs most commonly in conjunction with cirrhosis of the liver. and is associated with a 30 to 50% mortality rate. That's huge. Secondary peritonitis is also referred to as surgical peritonitis. This is an inflammation of all or part of the peritoneal cavity and is caused by diffuse microbial proliferation and chemical irritation from leakage of the corrosive gastric or intestinal contents into the peritoneum. Ruptured appendix, perforated peptic ulcer, bowel rupture related to an ulcerated colonitis, Crohn's disease, pancreatitis, abdominal trauma. These are just some of the things, associated with peritonitis. Indwelling tubes and catheters, such as those used for postoperative drainage and continuous ambulatory peritoneal dialysis. They're foreign bodies that compromise the peritoneal integrity and permit the entry of infective organs that can trigger peritonitis. Regardless of the initiating factor, the inflammatory process is similar in every case. The initial reactions, which usually are triggered by histamine release, include hyperemia, edema, and vascular congestion. Fluid shifts from the intravascular to the interstitial spaces as a result of the increased vascular permeability. The circulating blood volume is depleted and hypovolemic shock may ensue. The fluid contains high levels of fibrogen and thromboplastin. The fibrogen is converted to fibrin by the thromboplasm. Under normal peritoneal conditions, the peritoneum has fibrolytic abilities to stop the fibrin formation. However, when the peritoneum is weakened or damaged, this ability is diminished and fibrin adhesions form around the damaged tissues. These adhesions actually form a barrier that protects bacteria from natural body defense mechanisms, resulting in pockets of infection. This can lead to recurrent infections and septicemia. In other words, this process builds up a dam around the infection where our natural blood cells can't get in there to kill. That's what I said, basically. When assessing for existing risk factors, consider the histories of the patient. They could have diabetes, vascular disease, advanced liver disease, malnutrition, certain inflammatory processes such as diverticulitis, appendicitis, Crohn's disease must be noted. The primary clinical presentation is pain, which may be quite severe. The onset can be sudden or insidious, with location dependent on the underlying pathophysiology. Fever and restlessness are common, along with nausea, vomiting, anorexia, and changes in bowel habits. Physical auscultation of the 4 quadrants usually reveals diminished or absent bowel sounds. Again, not a great sign. A complete absence of bowel sounds commonly indicates there's an ileus, which is a frequent complication of peritonitis. Palpitation of the abdomen elicits generalized or localized tenderness, depending on the nature and extent of infection. Rebound tenderness, guarding, and rigidity are common. Respiratory rate is usually rapid with shallow ventilator pattern to minimize abdominal movement and pain. As a consequence, breath sounds are diminished, as you can imagine. Fluid shifts and hypovolemia may cause the client to appear restless, confused, due to impaired cerebral perfusion. Okay, sorry about that. Body temperature will likely be evaluated, accompanied by increased respiratory rate, increased pulse, as a result of the increased metabolic demands. In this acute phase, the cardiovascular system may be compromised by large fluid shifts from the intervascular space into the abdominal interstitium and peritoneum. The change in volume often leads to marked tachycardia, hypotension, decreased cardiac output, and decreased pulmonary pressures. Ultimately, if the condition persists, impairments in renal, cardiac, and cerebral perfusion will be noted. You will see them. So what are some of the diagnostic procedures? Leukocytes will be present. On the opposite end of the spectrum, if the WBCs are low, this might indicate an exhausted bone marrow. This is an extremely poor prognosis. The hemoglobin hematocrit may initially be elevated because of the existing hemol concentration. However, as intravascular volume is restored, these should return to normal. As peritonitis increases in severity, electrolytes may become abnormal. If the client is nauseated and vomiting, metabolic alkalosis might exist. This state is reflected by high CO2 and low chloride levels. Serum albumin levels are decreased, especially with bacterial peritonitis. Patients with peritonitis as a result of pancreatitis will show elevated amylase levels. Some of the radiological procedures will show dilation of the large and small bowel. If free air is noted in the abdomen, visceral perforation may be suspected. Free air is never good. A CT of the abdomen may show abscesses that, when visualized, can actually be evacuated during the procedure, negating the need for surgery. Ultrasound is useful to locate small amounts of located fluid, identifying abscesses, bile duct dilations, and pancreatitis. Abdominal paracentesis involves the insertion of a catheter into the abdomen to obtain a specimen. This fluid is then examined for RBCs, WBCs, amylase, and bacterial content. All right, so these two images, you see the one on the left with all the arrows, that is all free air. So this person probably has a perf, and see how big their belly is? Okay, the yellow right here, this is also free air. But can you see the difference? This one on the right is probably just starting. Okay, so I did mean to shock you with this. So sorry about that. I forgot that was on the next slide. So as you can see here, there are things inserted into the rectum. Okay, on the right, it looks like some kind of soda bottle. On the left is a toy for adults. I'm showing you these not for shock factor at all, you guys. What I'm telling you is you will see patients come in with all kinds of things. All kinds of things, okay? You have to be respectful and understanding, meaning understanding that they're a patient. You know, you may not understand what's happening here, but, you know, this is not that uncommon. I go back to when I worked at Good Sam downtown. A gentleman came in and he had a carrot in his rectum. Yes, a carrot. He was in a lot of pain. We were waiting for surgery. I did ask him, I just had to. I said, why a carrot? And he said, because they were on sale. Okay, so, I mean, this is just my life in the ER kind of thing. So the biggest thing is you're going to assess them. For trauma, they're going to need surgery many times, because if they could get it out, they would have gotten it out. But that's the thing about the anal sphincter, is once something goes in, if you don't have control of it, it sucks it up in there. And that's what it's meant to do. So the biggest concern is maintaining professionalism and respect the patient, no matter what you might see. All right. So collaborative management includes the implementation of doing an antimicrobial therapy in which some of the broad spectrum antibiotics, cephalosporins, could be ordered. These cephalosporins have reduced the amount of, or I should say, has reduced the risk for a nephrotoxicity. Analgesics must be utilized to ensure the patient's comfort, but given cautiously to avoid compromise of any abdominal respiratory function. Crystalloids or balanced salt solutions like normal saline are capable of passing through the semipermeable membrane. Colloidal solutions such as albumin may be indicated to increase intravascular protein. If peritonitis is complicated by hemorrhage, packed RBCs may be ordered. Because of the inflammatory process, GI function is compromised and motility is minimal or absent. A NG tube may be inserted to reduce or prevent distension and promote function. Patients will initially be NPO until GI function is regained. You guys know that. TPN is crucial for healing and survival until a feeding tube can be tolerated. Once bowel function has returned, internal nutrition with a feeding tube is appropriate. So they could do some surgery, a laparotomy. This focuses on controlling the contamination and removing foreign material from the peritoneal activity. and draining collective fluid. This procedure is also indicated to repair or remove perforated organs. Okay. Okay. Otherwise known as gallbladder. Okay. The incidence of gallstones increases with age and are more common in women than men. Again, ladies, goody for us. In this section, I only will discuss gallstones or cholecystitis specifically. Gallstones vary in size and can be small like a pea or large as a football. Patients can have multiple stones or single stones blocking the cystic duct or common bile duct. In your assessment of this patient, you may note that the patient's chief complaint of right upper quadrant pain. On examination, you may note tenderness and guarding. The pain may be described as colicky in nature, which is intermittent and radiating to the back. This pain is to rule out the movement of gallstones through the bile ducts as the bile flows. The WBCs will be elevated as a result of the inflammation, and the liver enzymes elevated as a result of the bile flow obstruction. The likely surgical procedure will be laparoscopic cholecystectomy. Similarly to what we have discussed previously, the items listed are an overview of your assessment needs post-op. And I'll mention a few of them for you. Fever is from the inflammation, tachycardia, anxiety or pain, decreased blood pressure, dehydration, inflammatory response. Electrolyte monitoring is needed because the patient may be dehydrated from previous nausea, vomiting, or lack of intake. Skin turgor, right? You're looking for tenting. Eyes and nose, monitoring their fluid status. Okay? All right. So here is the anatomy and physiology of the liver. The liver is the largest internal organ of the body. Remember, it is located in the right upper abdominal quadrant. The basic functional unit of the liver is the liver lobule, shown here. Okay? That's what it looks like. Hepatic cells are arranged in cords that spread out from central vein into the outer edges. Blood from the portal arterioles and venules empties into channels called sinusoids. Lining the walls of the sinusoids are specialized phagocytic gills called Kupffer cells. These cells move bacteria and other foreign material from the blood. The liver has a rich blood supply, receiving blood from both the hepatic artery and portal vein, which drains structures of the GI tract. The blood supplied in the liver by these two vessels accounts for approximately 25% of your cardiac output. So just so we can refresh on hepatic circulation, this diagram is from the cardiovascular circulation system. You can see how extensive percentage of circular volume is directed into the portal circulation in the center of the diagram. So see the liver in the middle? That's why it's so vascular. All right, what does the liver do? Blood storage. Resistance to blood flow, hepatic vascular resistance, what it's called, in the liver is normally low. Any increase in pressure in the veins that drain the liver causes blood to accumulate in the sinusoids, which store up to 400 milliliters of blood. This blood volume serves as a compensatory mechanism in cases of hypovolemic shock. So you've got some storage. Blood from the liver is shunted into the circulation to increase blood volume. It also does blood filtration. The Kupffer cells that line the sinusoids cleanse the blood of bacteria and foreign material that have been absorbed through the GI tract. These cells are extremely phagocytotic and thus normally prevent almost all bacteria from reaching the systemic circulation. So the secretory functions include that of bile production and bilirubin metabolism. Bile secretion is a major liver function, about 500 milliliters to 1,000 milliliters a day. Bile is made up of water, electrolytes, bile salts, phospholipids, cholesterol, and bilirubin. Bile salts emulsify fats and promote their absorption. The salts are reabsorbed in the terminal portion of the ileum and are then transported back to the liver, where they can be used again. Bile travels to the gallbladder via the common bile duct where it is stored and concentrated. Remember that bilirubin is a metabolic end product of degradation of hemoglobin, so when it breaks down. It enters the circulatory bound to albumin and is unconjunctated, reflected in the indirect serum bilirubin level. Now, if this bilirubin accumulates, it becomes toxic to cells. Therefore, in a healthy liver, bilirubin is conjunctated with glyceric acid. Okay, this bilirubin is soluble and excreted in the bile. Some bilirubin will return to the blood and will be reflected in the direct serum bilirubin level. The liver also stores synthesis and transports various vitamins and minerals. It has the capacity to store vitamin A for 3 months, vitamin D for 10 months, vitamin B12 for 12 months to accommodate deficiency states. And by the way, you guys, the stuff I talked to you about the bilirubin, just take that as an FYI. So when you get back into clinical, you'll know that. I'm not going to test you on that on the exam, but just FYI on that. All right, where are some of the functions? The liver plays an important role in glucose concentration. When blood glucose is greater than normal, it is stored as glycogenesis. As serum glucose declines, the stored glycogen is split to form glucose. As blood glucose levels decrease to below normal and the glycogen is depleted, the liver can make glucose from proteins and fats. Although many cellular structures have the capability of lipid metabolism, the liver metabolizes fats very rapidly. It also is capable of converting excess carbohydrates and proteins to triglycerides. Now, this is showing a comparison of a normal liver and the difference in the liver tissue of a normal liver and that of NASH. You guys see how fatty that NASH one is? What is NASH, you say? Well, let's take a look. Okay? It's called non-alcoholic fatty liver disease. Okay? NAFLD or non-alcoholic steatohepatitis. It doesn't matter. They're all the same thing, basically. I mean, give or take. In North America, NASH is the third most common cause of chronic liver disease following alcoholic liver disease and Hep C. It is interesting to note that obese children with an AST or an ALT greater than 200 or any elevation of AST or ALT for more than 6 months have a strong likelihood of having NASH without fibrosis, cirrhosis, or both. So that's really big on that if kids have that elevation from their liver without even having a disease, they can get this. So manifestation of metabolic syndrome. It's a collection of risk factors for cardiovascular disease and type 2 diabetes occurring together as recognized as metabolic syndrome. Significant risk factors of NAFLD or NASH are central obesity, diabetes, hyperlipidemia, and hypertension. Those of female gender are also a component. Oh, aren't we lucky again, ladies? NAFLD may occur in up to 75% of those type 2 diabetics. It is believed that obesity may be confounding variable in a statistic. Non-alcoholic fatty liver disease is now the most common liver disease in both adults and children worldwide. As a disease spectrum, NAFLD may progress from simple stenosis and advanced fibrosis to cirrhosis. An estimated 20 to 35% of general population has stenosis. Okay, 10% will develop a more progressive disease and have liver-related mortality. Early assessment is important to determine the accurate diagnosis. Patients with NASH will frequently present with the very nonspecific symptoms of weakness, fatigue, and malaise. Keep in mind that though similarities exist, the effects of the diseases of NASH patients are more asymptomatic, whereas alcoholic hepatitis are always symptomatic. Okay. Diagnostic studies will show elevations of ALT and AST. and radioactive changes will indicate fatty and enlarged liver. Okay. Clinical histories are necessary to exclude significant alcohol consumption. So document dietary history, medication use, occupational exposure, all that. A liver biopsy is necessary to confirm the diagnosis and offer prognosis information. Currently, there are no treatments that have proven effective in this disease. So that's just a bummer. All right, we're going to move to jaundice now. Okay, hepatic cellular viral hepatitis cirrhosis. You can see it in the eyes. Hepatic cellular. When thinking about the functions, remember that excessive accumulation of bilirubin is a blood results in jaundice. Oh my gosh, was that English? Anyway, basically, when the blood accumulates bilirubin, it results in jaundice or yellowing of the skin and eyes, fingernails. There are 3 commonly noted categories of jaundice. Viral hepatitis is the most common cause of hepatocellulitis jaundice caused by hepatic cell damage. Cirrhosis and liver cancer can also reduce the liver's ability to calm down the bilirubin. Hemolytic jaundice results from increased RBC destruction, such as that resulting from blood incompatibilities in sickle cell disease. Obstructive jaundice is most commonly the result of gallbladder disease, in which gallstones and or sludge are obstructing the common duct. The one thing I want to tell you guys too about liver disease or people that have jaundice is not automatic that they are alcoholics. Cirrhosis of the liver can be caused by many things: cancer, medication, other diseases. Is alcohol one of them? Alcoholic? Sure, absolutely. But don't assume anything. You have to get a history. All right, hepatitis. You guys have heard of hepatitis. It's an acute inflammatory process with the hepatocytes of the liver. Cellular edema accompanies this process. Under normal conditions, the functional units of the liver lobes, have their own blood supply, allowing these cells to be continuously exposed to an abundant blood supply. As the inflammation progresses, the normal pattern of liver is disturbed by the inflammation, interrupting the normal blood supply, causing necrosis and breakdown of health cells. Blood then backs up in the portal system, causing increased pressure known as portal hypertension. The good news is that the liver cells possess a great capacity to regenerate. Over time, liver cells that are damaged are removed from the body's immune system and are replaced with healthy liver cells. Therefore, most patients with hepatitis will recover and regain normal liver functions. Okay, here's the type of hepatitis, the route, the severity, and things that we can do. Hepatitis is the most often the result of a viral disease process. Currently, 6 forms have been identified, and research continues to study other potential viruses that are believed to be associated with acute hepatitis. Modes of transmission include contact with blood, blood products, semen, saliva, and percutaneously through mucous membranes and direct contact with infected fluid or objects. The characteristics of hepatitis in terms of type, route of transmission, severity, and prophylaxis are listed on the table. There is a vaccine called the Twinrix, listed here in combination of the antigen components and a suspension of inactivated Hep A virus, along with the purified surface antigen of the hepatitis B virus. That is what Twinrix is, and it's worked pretty well. So the biggest thing, I think the biggest takeaway with hepatitis is blood products, semen, saliva. That's why you practice universal precautions. You're always wearing gloves, washing your hands. So assessment. Patients with hepatitis are often asymptomatic. In many cases, reports of anorexia, nausea, vomiting, abdominal pain, and fatigue may be received from your clients. These may then progress to an objective determinations of a low-grade fever, palpably enlarged or tender liver, and jaundice. In severe cases, acute liver failure may be an outcome. It is important for you to obtain an accurate list of potential risk factors from the previous slide, for example. Liver function test results will be elevated. Lab diagnosis will indicate an elevated ALT and AST. Albumin will be decreased, serum bilirubin will be elevated, and protein will be elevated. Antibiotic identification for specific type of hepatitis will be conducted, so we know which one they have. All right, some interventions. Treatments will include home management as well. Patients must be instructed to get plenty of rest. Diets will be high in carbs, high in protein, and low in fat. Nursing care involves pain relief and encouraging individuals to resume normal activities and monitor liver function. Any medication that is administered to help the patient rest or to decrease agitation must be closely monitored because most require clearance by the liver. It's already impaired by this disease process. So you don't need it sitting in the liver and we keep giving the same med and then they're unconscious or not breathing. Okay? Health teaching will include hand washing. Isn't that surprising that we still have to teach that? Immune serum globulin is recommended for all household contacts. For Hep A vaccine, 2 doses will be administered. Recommended for travelers and those working with children. Immunization of Hep B or the Ritonavir is the 3 injections, which is what we all had to have. Okay, as cautious. You know, I've had that. The Hep B's like, I don't know, 3 or 4 times. They draw my blood, and I don't have any antibodies against it. Isn't that crazy? It just doesn't work for me. Okay, some anyway, things that are toxic to your liver. All right. I know you guys have to listen to this for a couple hours, but just try talking. And you guys aren't in the room. I don't like this, but it is what it is, right? Okay, because I feed off your energy. Anyway, as you see, anything we can possibly take as a medication can be toxic to your liver. All right. So researchers believe that MAOIs relieve depression by preventing the enzyme monoamine oxidase from metabolizing the neurotransmitters, norepinephrine, serotonin, and dopamine in the brain. As a result, these levels remain high in the brain, boosting mood. So that's an MOI. So that's why those are the ones that use for mental health. All right. Here's cirrhosis. Icky. Cirrhosis causes severe alterations in the structure of the function of the liver cells. It is characterized by inflammation and liver cell necrosis that may be focal or diffuse. Fat deposits may also be present. The enlarged liver cells cause compression of the liver lobe and lead to increased resistance to blood flow and portal hypertension. Necrosis is followed by regeneration of the liver tissue, but not in normal fashion. Fibrous tissue is laid down over time, and this distorts the normal design of liver lobes. These fibrotic changes are usually irreversible, resulting in chronic liver dysfunction. There are different types of cirrhosis. If you take a look at the categories and origins of the different types of cirrhosis, you can see that it is really inappropriate to assume, like I said before, that all patients with cirrhosis are long-standing alcohol abusers. You can see that it has biliary, cardiac, and post-necrotic sources of development as well. So remember, just don't assume because you don't know. Okay, on the initial assessment, you may note subjective complaints of weakness and fatigue, decreased appetite, weight loss, GI complaints, discomfort. Liver functions changes occur as cellular destruction progresses. The results of these changes are portal hypertension. This causes 2 main issues for the patient: hyperdynamic circulation and development of esophageal or gastric varices. The destruction of liver cells causes shunting of the blood and increased cardiac output. Vasodilation is present, causing decreased perfusion to all body organs in spite of an increased cardiac output. Symptomatology is similar to that of heart failure. BP decreases and dysrhythmias are common. Impaired liver metabolic processes result in changes in metabolism of carbs, fat, and protein. Blood sugar levels will elevate. Because fat is used for energy, activity tolerance may be diminished. Malnutrition often results from altered carb metabolism. Low albumin levels often result in ascites. Decreased synthesis of blood clotting factors and decreased removal of activity clotting components. Fibrogen is an essential protein that is necessary for normal clotting. Now that plasma fibrogen levels are low and the patient is experiencing a decrease in synthesis of clotting factors, these folks are predisposed to bleeding. Because the liver is now unable to remove activated clotting factors from the general circulation, they are also predisposed to general clotting, often leading to pulmonary embolus. Decreased metabolism of vitamins and iron, decreased metabolism of storage of vitamins A, B12, and D, and of iron, glucose, and fat place the client at risk of nutritional deficiencies. Decreased detoxification functions result in the inability of the liver to detoxify drugs, ammonia, and hormones. Loss of ammonia conversion to urea is the cause of mental alteration from confusion to coma. Remember, an increase in ammonia level makes people kind of funky. They get disoriented. On the next slide, I just lost my train of thought. On the next slide, there's a diagram that will demonstrate the flow of events of hormonal imbalance. So, hope that helps some. The alterations that you see in the lab values here are a direct result of the destruction of hepatic cells or impairment in liver metabolic processes. Liver biopsy may be performed to study the composition of a liver cell. An ultrasound study may be conducted to identify impaired flow of bile. Esophageal varices. In the esophagus, esophageal varices are the most common cause of massive hemorrhage. In chronic liver failure, liver cell structure and function are impaired, resulting in increased portal venous pressure or portal hypertension. As a result, part of the venous blood in the splenic system is diverted from the liver to the systemic circulation by development of connections to neighboring low-pressure veins. This is called collateral circulation. The most common sites for the development of these collateral channels are the submucosa of the esophagus and the rectum, the anterior abdominal wall, and the parietal peritoneum. As these veins experience increase in pressure, they become distended with blood, the vessels enlarge, and various development, most commonly in the esophagus and upper portions of the stomach. They have a low tolerance for pressure increases, thus have a tendency to bleed. Mallory-Weiss syndrome is a laceration of the esophageal junction and results in massive bleeding. There's a picture there for you. This is the outcome of maneuvers that increase intra-abdominal pressure, such as retching, vomiting, straining, or coughing. It is associated with long-term non-steroidal anti-inflammatory drug or aspirin ingestion and with excess alcohol intake. So this top picture too is showing you, if we were to put a scope down, what it would look like. All right. The Blakemore tube is on the left, the Minnesota tube is on the right. Specifically designed tubes for the esophageal varices bleeding are utilized to protect the airway and to tamponade or clamp off the bleeding sites. The Blakemore tube has 3 separate openings. One lumen inflates the gastric balloon. Another inflated the esophageal balloon. And the third one is used to aspirate the blood from the stomach. With this tube, an additional tube must be placed for the proximal esophagus for suction. The Minnesota tube has 4 lumens. The Minnesota esophageal tamponade tube includes an esophageal aspiration lumen. As a nurse, you are responsible for maintaining balloon lumen pressures and patency of the system. Ideally, the balloon should be deflated every 8 to 12 hours to decompress the esophagus and gastric mucosa. If deflated, the esophageal balloon is deflated before the gastric balloon, or else the entire tube will be displaced upward and will occlude the airway. Okay, so that's your biggest issue with any of these tubes is airway. It's airway. Esophageal rupture may also occur and is characterized by the abrupt onset of severe pain. In the event of either of these 2 life-threatening emergencies, all 3 lumina are cut and the entire tube is removed. Scissors should be kept at the patient's bedside at all times because of this. The tube inhibits the ability to clear oral secretions, So endotracheal intubation may be required to protect the airway depending on the patient. Sores can develop around the mouth and nose as a result of the devices. All right. Hemodynamic instability and decreased perfusion to core organs are the end result of portal hypertension and hyperdynamic circulation. Invasive monitoring may be used, but consideration must be given for the increased potential for infection as a result of existing impaired immune responses. Blood pressure and kidney perfusion will be supported by vasoactive drugs and fluid. Because glycogen stores are depleted and patients experience liver failure, lose the ability for glycogenesis, hypoglycemia is common and requires frequent monitoring. Remember that these patients are at an increased risk for bleeding due to decrease in synthesis of clotting factors. You will need to provide protection in the form of padded side rails and assistance with activities. In severe cases, you may be administering blood products. Also, gastritis and stress ulcers are common in liver failure. So, antacids, protein pump inhibitors, and H2 blockers may be ordered. All right, so we're going to move on to pancreatitis. Acute pancreatitis is an inflammation of the pancreas. Mild pancreatitis may also present with abdominal pain and elevated amylase and lipase levels. Severe pancreatitis may result in multiple organ failure. 85 to 90% of patients have acute mild pancreatitis and recover quickly. However, high mortality rates are associated with the more severe forms of the disease. The foremost theory relating to the etiology of pancreatitis is that injury to the pancreatic cells causes leakage of the pancreatic enzymes into the pancreatic tissue. These enzymes are responsible for the process of autodigestion, a breakdown of the tissue and cell membranes, causing edema, vascular damage, hemorrhage, and necrosis and fibrous issues. The now toxic enzymes are released into the bloodstream, causing injury to vessel and organ systems like the hepatic and renal. That's what pancreatitis is, or so we think. All right, so this gives you an idea of the widespread potential complication that your patients are at risk for with pancreatitis. It's no joke. In most cases, patients with acute pancreatitis present with severe abdominal pain. The pain is epigastric or mid-abdominal, often radiating to the back. This pain is the result of edema, chemical irritation and inflammation of the peritoneum and irritation or obstruction of the biliary tract. Nausea and vomiting are quite common. Abdominal distension accompanies the bowel symptoms in addition to the accumulation of fluid in the peritoneal cavity. Their tummy gets bigger, and they have hypoactive bowel sounds. This fluid contains enzymes and kinins that increase vascular permeability and dilate the blood vessels. Hypotension and shock occur from intravascular volume depletion, which then results in myocardial insufficiency. So your heart's not working so great. Fever and leukocytes are also symptoms of the inflammatory process. There are two rare signs, Collins sign and Gray-Turner sign. These are indicative of retroperitoneal hemorrhage and are visible either in the flanks or the umbilicus area. So you can see Collins sign is where the belly button is, and on the flank is Gray-Turner sign. Okay, CT scanning is the principal diagnostic tool. Ultrasound is useful to identify the location of if there's a potential cyst formation, masses, and hemorrhage. ERCs combine radiological, endoscopy, and may assist in the diagnosis. ERCP. All right, so fluid replacement is significant intervention for patients with acute pancreatitis. These people may isolate up to a third of their plasma volume in the retroperitoneal space and peritoneal cavity. In other words, a third of their plasma volume is in their belly. Initially, most will show signs of dehydration, potentially leading to severe shock. Because hypovolemia and shock are major causes of death early in the disease process, fluid replacement is a high priority. Crystal light solutions, such as normal saline or LR. However, colloid solutions such as FFP and albumin may be indicated. For all those reasons, guys, that we talked about why you use colloids. Increased loss of calcium from circulation in the abdomen often results in hypocalcemic states and associated with high mortality rates. Remember that calcium is essential for catalyzing impulses for nerves and muscles, maintaining cell membrane and vessel integrity, for blood clotting, bone strengthening, and cardiac contractility. Calcium replacement as a result of fat necrosis may be necessary. As a nurse, you will be monitoring calcium levels and watching for signs of calcium toxicity, which are nausea, lethargy, lengthening QT interval, decreased muscle and nerve excitability. Potassium supplements may be indicated to prevent cardiac dysrhythmias, muscle weakness, hypotension, and ileus. Hyperglycemia may result from the stress of the illness. During the initial stages of pancreatitis, NPO status is the norm along with NG suction. This reduces pancreatic enzyme secretions, vomiting, and abdominal pain. Patients with an ileus, gastric detention, and decreased LC also benefit from NG prevention of aspiration. Once NPO status is reversed, small frequent feedings are indicated. Diet should be planned, high in protein, carbs, and low in fats. Pain control is essential. This is super painful, you guys. Opioids may be evaluated. Morphine often causes spasm of the sphincter, which increases pain. So you might use something else. Also, patient positioning must be addressed. If hemodynamic status permits, side lying and slightly elevated head may be more comfortable. So, some pharm interventions include the use of histamine blockers and antacids to prevent stress ulcers. Antibiotic use is thought to prevent pseudocysts, abscesses, and septic complications. Some doctors order that, some do not. Pulmonary complications are common in patients with both mild and severe manifestation of pancreatitis. Accumulation of fluid in the peritoneum restricts movement of the diaphragm, so O2 sats and ABGs must be continuously monitored. If your gut is so big you can't take a deep breath, then your respiratory status could be compromised. That's what that means. Coagulation, abnormalities, and hemorrhage are risk factors to be considered. Monitor bleeding times and assess frequent vital signs and physical evaluations for signs and symptoms. Coagulation abnormalities are associated with high mortality rates. Cardiovascular rhythms, fluid status, and renal function is essential to monitor as well, your BUN and creatinines. Surgical interventions include pancreatic resection for acute necrotizing pancreatitis. Internal, external, or needle aspirations of pseudocysts is often performed, and cholecystectomy is carried out if gallstones are believed to be the causative pathological condition that leads to the pancreatitis. So I like this photo because I thought it was more like COVID-19 with us all home. I hope that helped you guys. Again, as usual, any questions, please let me know. All right? And I will see you all later.